So my name is Niklas Huntemann. I am working as a physician and researcher at the University Hospital in Düsseldorf in the clinics for neurology. So a long time ago, it's known that years ago we had not that many treatment options. We had steroids and so on, and I mean many people had a sufficient disease control, but there are still patients who did not respond well to these standard immunosuppression. And now we have two new mechanisms of action. We have the complement inhibition and FcRn inhibition. So the complement inhibition with three therapies, the eculizumab, ravulizumab, and zilucoplan, is crucial since it does a terminal complement inhibition, and the complement inhibition or the complement system itself is important in the pathophysiology of generalized Myasthenia Gravis. You can see it in the histology, you can and so on, and therefore these new mechanisms or this complement inhibition showed promising effects in many patients. The other mechanism is the neonatal FcRn Antagonism. The neonatal FcRn receptor is important for the recycling of IgGs, and among them are the anti-acetylcholine receptor antibodies. And by interfering with this neonatal FcRn receptor, there's a reduction of IgG levels and also of the pathogenic antibodies in Myasthenia Gravis. Therefore, it's also a working mechanism for not only acetylcholine positive patients, but also for example, MuSK positive patients. So I presented a poster on the both mechanisms. As I said, these new mechanisms are there now for some years. But however, we do not really know if one treatment modality is superior to the other one, or if there are patients who should be on FcRn inhibition or on complement inhibition. So therefore, we did this comparative analysis of patients which were treated with either eculizumab or ravulizumab or with efgartigimod at the University Hospital in Düsseldorf at the neurology here, and had a look on the safety and also on the efficacy of these treatments. And we did not see significant differences. So the positive thing is that we saw a very rapid decline in MG scores. So patients' quality of life improved very fast. And also we saw sustained reduction in MG scores, but however we did not see differences. There's actually a paper coming in which we did the same in 8 German MG centers. We included 153 patients, 106 under eculizumab and ravulizumab, and 47 under efgartigimod. And we did the same here. First, we did a characterization of the cohorts to show real-world data, and afterwards we did a direct comparison of these mechanisms using propensity score matching to overcome imbalances between the two study cohorts. And again, here we included after propensity score matching, which was based on the MG-ADL at baseline, the QMVG at baseline, the age, and so on, and we did not see significant differences. So both therapies worked well in many patients, but we did not see superiority of one of these treatment modalities. However, there were still about 30 to 40, 50%, depending on the score, which did not respond well, and which is still, this were treatment refractory patients, or the most were treatment refractory patients, but there are still patients who did not profit in a sufficient way. We had some cases which then switched from complement inhibition to FcRn antagonism or vice versa, and many of these patients showed improvement under that. So there's a rationale to, if one mechanism is not working, to maybe change to the other mechanism. But however, there's still the need for new therapies. First, but I think another aspect that should be the topic of future studies is to identify predictive factors. So we still do not really know which patient we should go with, complement inhibition, or for which we should go with FcRn antagonism. And I think therefore this is the challenge of the next years.